Hi, are you a PA or MP or med students about to take your psych exam? Well, studying for a psych exam can be overwhelming, but you're not doing this alone. In this video, we're going to tackle 60 high-yield real mock questions together, break them down each one by one with the answers that will make sense and make the hard stuff stick. And by the end of this video, you will feel more confident and ready to crush your next exam. This is going to be the video number 1, in which we'll cover 60 questions one by one. And in video 2, I will give you 60 minutes so you can answer the questions by yourself on your own time and see the answers later. But in this video, we'll go one by one and let's see how many you get right. One tip, what really significantly helped me improve my grades was a good test taking strategy. And the test taking strategy that I utilize is when it comes to the questions, like in a PA school, you're going to have, for the EOR, for example, you're going to have 120 minutes for 120 questions. So it breaks it down for about, a minute per question. So having a good test taking strategy can make you or break you. So one of the things that significantly improved my grades was to read the last sentence first. This allows me to focus on what the question is asking without all the big fluff in STEM. What is the most likely diagnosis? And then I would look at answers: major depressive, hypomanic, manic, cytothymic, and I know most of the stuff for this for my high yield review and for my study material. So with that in mind, what is the most likely diagnosis? I looked at answers, so they basically asked me whatever this person is presenting with, it's one of these. So let's get to it. A 23-year-old college student is brought in by her roommate for erratic behavior over the last 5 days. That is important. So in psych and like in most of the diseases and disorders, pay attention to the time frame, because the time frame can be the most important aspect of picking couple of answers that are really alike, but they can be differentiated by time. So over the last 5 days, she has slept only 3 hours per night, bought expensive clothes, impulsivity, and pressure her friends into the late night business plans. She is distractible, euphoric, and became irritable when interrupted. Urine text screen is negative. There is no psychosis. What is the most likely diagnosis? Major depressive disorder, hypomanic, manic, cyclothymic. And the answer is manic. So manic episodes will last greater than 7 days and marked impairment. And her impairment, she's staying all up night, she's working on her business plan, only sleeping 3 hours, she's irritable all over the place. MDD has no mania, so you know that is incorrect. And hypomania, it lasts 4 days, but no marked impairment. That's the way you differentiate manic from hypomanic episodes. Hypomanic will last less than 5 days, less than 5 days. Here's only 4 days and no marked impairment. In cyclothymic, it's chronic, mild mood swings. Neither one of those applies to cyclothymic disorder here. And the giveaway in this question was marked impairment equals mania, no hypomania. So, manic episode, correct answer. Next question. Which is the best initial treatment? Cognitive, behavioral therapy, long-term benzodiazepine, electroconvulsive therapy, or beta blockers. A 35-year-old male presents with a persistent anxiety for the last 8 months. He reports feeling on edge, difficulty concentrating, and a constant muscle tension. He says he worries excessively about his job, finances, and health. Even when reassured, he denies panic attacks, depression, or substance use. Physical exam and labs are normal. Which is the best initial treatment? I'll give you guys like 3 seconds. And the answer is CBT. So patient is definitely having greater than 6 months worth of anxiety, which is general anxiety disorder, and a first line treatment for that would be the CBT. You don't treat anxiety with benzos because of risk of dependence, and it's not a first line. ECT is only for severe refractory depression, not generalized anxiety disorder. Beta blockers are great for performance anxiety, not general anxiety disorder. And for performance anxiety, you would prescribe propranolol. So giveaway, general anxiety disorder, chronic worry, CBT plus SSRI or SNRI. So in this case, which is the best initial treatment? That would be cognitive behavioral therapy for general anxiety disorder, and you can add Prozac or some other SNRIs. I hope you guys are finding this really helpful. So, yeah, leave me a comment. Let me know what you think about this format. I would love to hear where you're coming from. What school are you going to? Where are you in your process of becoming a PA or MP? Yeah, just let's connect. Question number 3. Which is the most likely complication if untreated? Huntington disease, Korsakoff syndrome, Alzheimer's dementia, and frontotemporal dementia. A 41-year-old woman with a chronic alcohol use disorder presents with a new confusion, ataxia, nystagmus. On exam, she is disoriented, struggles to form new memories, and confabulates when asked about recent events. Her labs show low thiamine, which is the most likely complication if untreated. And that would be Korsakoff syndrome. So when it comes to Korsakoff syndrome, you're going to think about memory impairment, which she does have, and confabulation from B1 deficiency. So Huntington would be genetic chorea. Alzheimer's would be gradual. There's no acute with timing deficiency, and this lady definitely had some timing deficiency. And frontotemporal will be personality change, and it's not alcohol related. So the giveaway, she's a drinker, she has timing deficiency, Wernicke, Korsakoff. Question number 4. Which neurotransmitter system is most implicated? Dopamine, hyperactivity, serotonin dysregulation, acetylcholine depletion, and norepinephrine overactivity. A 27-year-old graduate student reports recurrent intrusive thoughts about contamination and spends hours washing her hands daily. She recognizes the thoughts and irritational but cannot stop herself. These behaviors interfere with her ability to finish assignments and have strained her relationship. Which neurotransmitting system is most implicated? And that would be serotonin dysregulation. OCD is linked to serotonin. Dopamine, you should be thinking about schizophrenia, psychosis, acetylcholine, it's your Alzheimer's and dementia, and norepinephrine is seen in panic disorders and PTSD. So giveaway, OCD, SSRI, serotonin. Question number 5. What is the most likely diagnosis? Bipolar I, Bipolar II, Cyclothymic, and dysthymia. A 29-year-old woman presents with fluctuating mood for the past 3 years. She has episodes of the mild depression alternating with periods of increased energy, but never meets criteria for mania, hypomania, or major depression. Symptoms cause significant distress, but no psychosis or hospitalization. What is the most likely diagnosis? Well, that is cyclothymic disorder. And one of the other ways you can go about the questions is once you see the answers, if you know your high yield information for it. So for bipolar 1, she would need to have mania. Bipolar 2, there's like no hypomania, but she's been dealing with this for 3 years. So you know that's a cyclothymic disorder, which is greater than 2 years with mild mood swings. Oops, let's go back. So bipolar 2, you're thinking hypomania and major depression. But she never meets the criteria for mania, hypomania, or major depression. So right there, that eliminates bipolar 1 and 2, and dysthymia is a chronic low mood only. There's no other increased energy. There's no alternating periods of depression and energy. That's what dysthymia is. So this is a clear presentation of cyclothymic disorder. All right, guys, I think this is a great time to tell you about the book that I just published. This is everything you need to know about a psychiatry EOR. It comes with a 120 style questions, just like the ones we're going through, and it also completely covers the entire content. It has 120 questions, step-by-step approach for each condition, memory hooks, mnemonics, exam tips, test strategies. Also has this don't confuse with comparisons for those tricky differentials, high yield facts all along. This book will significantly improve your scores. It will save you time. It will significantly cut the amount of time you need to study, and you can spend that time with your loved ones or spend time more on rotations to build those friendships and hopefully your future colleagues. All right, let's go on. Question number 6. Which complication is most life-threatening in this condition? Hypertension, cardiac arrhythmias, peptic ulcer disease, diabetes mellitus. A 16-year-old girl is brought by her parents due to the dramatic weight loss over the last 6 months. She avoids eating meals with her family, counts calories obsessively, and exercises excessively. Despite being underweight, she insists she is still too fat. Her BMI is 15. Which complication is most life-threatening in this condition? And when it comes to conditions that are presented, hypertension, cardiac arrhythmia, peptic ulcer disease, diabetes mellitus. I mean, if you didn't know anything about what this patient is presenting with, you could have just looked at it and be like, which one of these is most life-threatening? And of course, that's cardiac arrhythmia. So cardiac arrhythmias is the electrolyte disturbance is most lethal. Hypertension, unlikely, more hypotension. Peptic ulcers, it's not a primary risk, and diabetes is not associated with anorexia nervosa. So this patient presents with anorexia, and if left untreatment, can lead to arrhythmias and death. Question 7. What is the most likely diagnosis? Adjustment disorder, persistent depressive disorder, major depressive disorder, cyclothymic disorder. A 40-year-old man reports difficulty sleeping and concentrating since retiring 3 months ago. He feels worthless and guilty for being a burden. He has lost 12 pounds due to the poor appetite and endorses early morning awakenings. He denies mania or substance use. What is the most likely diagnosis? So let's look at the time frames. It's only been since he retired about 3 months ago. So that puts him in major depressive disorder. Cyclothymic disorder would be requiring him to go mood swings, but no pure depression. Persistent depressive disorder, it will have to be more than 2 years. And this has only been going on for about 3 months. So major depressive disorder is the depression for greater than 2 weeks with functional impairment and neurovegetative signs. And cyclothymic again, mood swings, no pure depression. Giveaway, this has been greater than 2 weeks with weight loss and guilt, major depressive disorder. So I hope you guys can see how knowing all that high yield information, time frames, and so forth can help you differentiate from the answers. So sometimes you just like read the last sentence, look at it, and you can see, okay, 3 months only. That rules out, persistent depressive disorder. Also, there's no pure depression. He just feels like a burden. Has poor appetite, so you can rule in or rule out a lot of these conditions just by paying attention to time and symptoms. Which is the most likely diagnosis? Brief psychotic disorder, schizophreniform disorder, schizophrenia, or schizoaffective disorder. A 32-year-old man presents with a hearing voices for the last 8 months. He believes neighbors are spying on him and frequently isolates himself. He denies mood symptoms and drug screening is negative. His functioning at work has declined and hygiene is poor. Which is the most likely diagnosis? This will be the schizophrenia. So because he has psychosis that are lasting greater than 6 months. Brief psychotic episodes are less than a month. Schizophreniform is 1 to 6 months, and schizoaffective would be psychosis plus the mood disorder. And he did not have any mood disorders. He denies mood symptoms. So giveaway, greater than 6 months of psychosis, schizophrenia. So right here you can learn how to differentiate these three. And you will say if it's lasting less than a month, that's just a brief psychotic episode. 1 month to 6, schizophreniform. Greater than 6 months of psychosis is schizophrenia. And for schizoaffective disorder, you need psychosis and the mood disorder. Question number 9. Which is the best pharmacological treatment? Benzo, buspirone, SSRI, or beta blocker? A 25-year-old woman reports excessive worrying for the past 10 months. She fears her parents will get sick, her grades will slip, or that accident will occur. She has trouble concentrating, controlling the worry, and experiences insomnia, restlessness, and frequent muscle tension. Which medication is best for her? Well, this is SSRI. Once again, we're dealing with general anxiety disorder. She reports excessive worrying for past 10 months. So right there, it tells you this is general anxiety disorder because it's lasting more than 6 months. And we know the first line medication treatment for general anxiety disorder is SSRI. Benzos, short-term only. Buspirone can be used, but SSRI is the first line. Beta blockers is for performance anxiety. Which is the most likely diagnosis? GAD, panic disorder, social anxiety disorder, illness anxiety disorder. A 19-year-old college student presents with a sudden fear, chest tightness, palpitations, and sweating that lasts about 15 minutes and resolves spontaneously. He now avoids leaving his dorm because he fears another attack may occur in public. Workup for cardiac disease is normal, which is the most likely diagnosis. This is a classical presentation of panic disorder. Recurrent, unexpected panic attacks and avoidance. Hint, panic disorder. So general anxiety disorder would be chronic worry, no discrete attacks. Social anxiety, fear of scrutiny, no random attacks. Illness anxiety, preoccupation with illness. So when he talked about 15 minutes, resolves spontaneously, he doesn't want to leave his dorms. Sudden fear, chest tightness, palpitations, all points to panic disorder. Which neurotransmitter is most deficient? Dopamine, acetylcholine, serotonin, or GABA. A 72-year-old man is brought by his daughter for worsening memory. He forgets names, misplaces objects, and repeats questions. On exam, he is oriented to a person but no place or time. MRI shows diffuse cortical atrophy. Which neurotransmitter is most deficient? That would be acetylcholine. So this patient presents with Alzheimer's dementia linked to cholinergic deficiency, as evident by diffuse cortical atrophy seen on imaging and forgetting names and places. Dopamine was seen in Parkinson's and schizophrenia. Serotonin is all about mood or OCD, and GABA is all about anxiety. So Alzheimer's, acetylcholine, and A for A. So Alzheimer's, acetylcholine. If you can't remember all of the neurotransmitters, so if you can say this is Alzheimer's disease, it affects the A neurotransmitter, A acetylcholine. What is the most likely diagnosis? Schizophrenia, schizoid personality disorder, schizotypal personality disorder, paranoid personality disorder. So knowing high yield stuff about every one of these, which you can find in a book, they're all in fine detail. It will help you pick the answer if you're pressed for time with the long stems. So what is the most likely diagnosis? A 30-year-old man presents with persistent suspicion that the co-workers are plotting against him. He avoids social interactions and is reluctant to share information and perceive benign comments as threat. He maintains employment and has no hallucinations or bizarre delusions. So this is a paranoid personality disorder. And you can tell that by the persuasive distrust without psychosis. So schizophrenia will require psychosis. This guy does not have it. He just doesn't trust his coworkers. They're plotting against him in his mind. He avoids social interactions. So it is all about paranoid. Schizoid would be social withdrawal, but no paranoia. That's how you differentiate it too. Schizotypal, odd beliefs, magical thinking. That's just something completely different from this presentation. So the only one that could have tricked you with was schizoid. But if you know that paranoid is persuasive distrust without psychosis, and schizoid is all about that social withdrawal, but no paranoia like this patient has with his coworkers. Which is the best next step in management? Start IV lorazepam, begin propranolol, stop antipsychotic and give dentrional, increase fluid intake only. A 23-year-old man presents with a sudden muscle rigidity, high fever, and automatic instability after antipsychotic initiation. Labs show elevated creatinine kinase, which is the next best step in management. As always, if you started some medication and it's causing patient to have some severe side effects like muscle rigidity, fever, instabilities, and so forth, you should stop that medication immediately and give dentrional, NMS treatment. Lorazepam is used for catatonia, propranolol, akathisia, not NMS, and fluid supported but not definitive. So giveaway, NMS, rigidity, fever, dentrional, or bromocriptine. So stop the antipsychotic and give dentrional. Which psychotherapy is most effective? The electrical behavior therapy, supportive, electroconvulsive, or cognitive processing therapy. A 33-year-old woman with borderline personality disorder presents after an argument with her partner. She alternates between praising and demeaning him, reports chronic emptiness, and has a history of self-harm. She denies psychosis or mania. Which psychotherapy is most effective? And that would be the DBT, evidence-based for borderline personality disorder. Supportive is not specific, it's not first line. ECT is for refractory depression, and CPT would be trauma focused, not for borderline. So, borderline, dialectic behavioral therapy. DBT for borderline. Which is most likely diagnosis? Illness, anxiety, somatic symptoms, or factitious and malingering. A 45-year-old woman presents with excessive preoccupation with having breast cancer despite multiple normal mammograms. She spends hours researching online and seeks repeated reassurance but continues to believe she has undiagnosed cancer. She has no somatic symptoms, which is the most likely diagnosis. This is a good explanation of what the illness anxiety disorder will look like. Fear of illness without any symptoms. Somatic symptoms, she would have physical symptoms present, factitious, intentional falsification, and malingering external incentive, like she's trying to make some money off of insurance or something. Factitious is just falsification of the symptoms, and the illness anxiety disorder is just pretty much this presentation. Fear of disease with no symptoms equals illness anxiety. Which is the most likely diagnosis? Persistent depressive, major depressive, adjustment disorder, cyclothymic disorder. A 42-year-old woman presents with a depressed mood, fatigue, and a lack of pleasure in daily activities for past 7 months. She reports early morning awakening, significant weight loss despite no dieting, and marketed guilt about being a bad mother. She denies hallucinations or delusions. Past medical histories are unremarkable. She has no history of manic or hypomanic episodes, which is the most likely diagnosis. So, past 7 months would be the major depressive disorder. So, greater than 2 weeks, classical melancholic features. Persistent depressive disorder must be 2 years. adjustment disorder tied to stressors, and it's usually less than 6 months. And cyclothymic is mood fluctuations, not a pure depression. So giveaway here will be the melancholic depression with guilt, weight loss, and early waking. So again, you can see how important it is to have that time frame and knowing that, it's only talking about 7 months, not greater than 2 years. That eliminates the persistent depressive disorder. Adjustment disorder is less than 6 months, and cyclothymic is only about mood fluctuation without depression. And this lady is depressed and it's been happening for 7 months. What is the most likely diagnosis? Schizoaffective, brief psychotic disorder, schizophreniform, and schizophrenia. So again, time frame is really important. A 23-year-old college student is brought to the emergency department after being found wandering campus disorganized and shouting at unseen people. He has a flat affect, poor grooming, and auditory hallucinations for the past 4 months. There is no history of drug or alcohol use, and urine tox is negative. He reports social withdrawal and declining grades. No manic or depressive episode are identified. What is the most likely diagnosis? All right. And this is a good example of the schizophreniform disorder. So it's only been 4 months. So between 1 to 6 months of psychotic symptoms qualifies it as a schizophreniform. Schizoaffective requires mood disorder episodes. Brief psychotic less than a month, and schizophrenia requires greater than 6 months. So giveaway was in time, and his psychotic episodes, so 4 months of psychosis, schizophreniform. Which is the best diagnosis? Panic disorder, GAD, PTSD, acute stress. A 30-year-old man reports feeling constantly on edge since returning from deployment 1 year ago. He experienced recurrent nightmares, intrusive thoughts of combat, and avoids crowded places. He has hypervigilance and an exaggerated startle response. Symptoms impair work and social life. He denies substance use. Which is the best diagnosis? And looking at the history of the patient and a length of time, this is a clear-cut PTSD case where trauma persisted greater than 1 month. So panic disorder, we'll see a panic episode, panic attack, but no trauma link. And general anxiety disorder is all about excessive worrying, also no trauma focused. And acute stress would be less than 1 month. So if this patient just presented and they say he's been feeling like this for the last 3 weeks, in that case, that would be acute stress. So, trauma greater than 1 month, PTSD. Which diagnosis is most likely? Bipolar I, cyclothymic, dysthymia, bipolar II. A 27-year-old man presents with fluctuating mood symptoms. Right there, it's pointing out to dysthymia or cyclothymic disorder. So we gotta see for past 3 years. So that makes me think cyclothymic disorder. He describes period of mild elevated mood with increased energy but no impairment, alternating with periods of mild depression. He has never had full-blown mania, hypomania, or major depression. He denies psychosis. Symptoms cause stress and difficulties in relationships but do not meet criteria for major mood episodes. Which diagnosis is most likely? Again, cyclothymic. So we're dealing with greater than 2 years of subthreshold mood swings. So mood swings for greater than 2 years, think cyclothymic. Bipolar I will require him to have mania. He never had mania. Dysthymia, only depressive symptoms, no hypomanic features. And because this patient had alternation with periods of mild depression. And bipolar II is hypomania plus major depression. This patient was never met the criteria for major mood episode. So giveaway, greater than 2 years of mild highs and lows, cyclothymic. Which diagnosis is most consistent? Specific phobia, GAD, panic disorder, social anxiety disorder. A 35-year-old woman presents with palpitations, sweating, and fear of dying that occurs suddenly without warning. She has had multiple episodes over the last 2 months, often in crowded areas. Between episodes, she worries about when the next attack will occur and avoids shopping centers. Physical exam and EKG are normal. Which diagnosis is most consistent? This is a good case of panic disorder. So recurrent, unexpected panic attacks plus worrying and avoidance. Specific phobia will be tied to one object or situation only. General anxiety disorder would be chronic worry, no episodic attacks. Social anxiety would be triggered by scrutiny, not a random. So giveaway for this question was recurrent, unexpected attacks plus avoidance of certain places equals panic disorder. Which personality disorder best explains his behavior? Schizoid, avoidant, dependent, paranoid. A 19-year-old college freshman has difficulty making friends. He avoids social interactions due to the fear of rejection, but he desires close relationships. He is described as shy and hesitant with low self-esteem. No psychosis or mood disorder is present. Which personality disorder best explains his behavior? This is a good case of avoidant personality disorder. So, avoidant personality disorder, they desire relationships, but they avoid it due to the fear of rejection. Schizoid, they do not desire relationships. Dependent, they're clingy, submissive. They'll make friends, but they'll have a hard time with breakups. They'll be like, yeah, super dependent. And paranoid, they're distrustful, suspicious. None of those apply to this patient. So giveaway, he wants friends but fears rejection. Avoidant personality disorder. Which is the best next step in management? Give propranolol, administer benztropine, start bromocriptine, discontinue haloperidol permanently. A 47-year-old man with the chronic schizophrenia is hospitalized for worsening auditory hallucinations. After starting haloperidol, he developed severe neck stiffness, oculogeric crisis, and tongue protrusion within 24 hours. Vitals are stable, which is the best next step in management. So for this patient with acute dystonia, we should administer benztropine, anticholinergic for acute dystonia. Propranolol will treat akathisia, not dystonia. Bromocriptine for neuroleptic malignant syndrome, not dystonia. And discontinue permanently, not first line for acute dystonia. So give away EPS, acute dystonia, benztropine, or diphenhydramine. So see, like when you look at the answers, the questions that they give you, A, B, C, D, you should have a really good idea what each one of them does. And then when you read the stem, you're like, okay, this patient is in acute dystonia. We gotta stop this. We're gonna administer benztropine. I hope I said that medication right, because some of these names are like crazy to pronounce. Which personality disorder is most likely? Histrionic, borderline, narcissistic, antisocial. So again, known bits about histrionic is somebody seeking attention. Borderline is a person that splits good people, bad people. There's like nothing in between. Narcissistic, they feel that they're better, entitled than anybody else, and antisocial, they just like avoid people. So a 33-year-old woman with a long-standing unstable relationships presents with a self-harming behavior after an argument with her partner. She describes chronic feeling of emptiness, fear of abandonment, and intense emotional swings. She has a history of impulsivity with spending and binge eating. Which personality disorder is most likely? Well, it's not histrionic, so it's definitely borderline. So unstable relationships, self-harm, fear of abandonment. So yeah, seeing the question stem about self-harm, unstable relationships, fear of abandonment, outbursts, black and white, nothing in gray, think borderline. Histrionic, attention seeker, dramatic, no self-harm. Narcissistic, grandiosity, lack of empathy, but no self-harm. Antisocial, disregard for rights of others. So giveaway self-harm plus unstable mood equals borderline personality disorder. Which treatment is most appropriate? Propranolol, diphenhydramine, lorazepam, bromocriptine. A 45-year-old man presents with restlessness and inability to sit still after starting risperidone 2 weeks ago. He frequently paces during the interview and says he feels an inner agitation. Symptoms improve temporarily with walking. Which treatment is most appropriate? That would be propranolol. So this patient presents with akathisia, inner agitation. He's unable to sit still. He's pacing. He started risperidone 2 weeks ago. Put those two together, you can see the side effects becoming akathisia, and we treat that with propranolol. Diphenhydramine for dystonia, not akathisia. Lorazepam sometimes used, but it's not a first line. And bromocriptine is for NMS. So either restlessness equals akathisia, give them propranolol. You guys will do great in this exam. So hopefully these questions are really helpful as well. Which is the most likely diagnosis? Schizoid personality disorder, schizophrenia, paranoid personality disorder, and delusional disorder. A 54-year-old woman is brought in by her family because she believes her neighbors are plotting to harm her. She has no hallucinations, but expresses pervasive suspiciousness and interprets benign comments as threatening. She had no mood symptoms or disorganized thoughts. Functioning is intact aside from social isolation, which is the most likely diagnosis. Well, this is a good example of paranoid personality disorder, pervasive suspiciousness without psychosis. So, you can see that she expresses pervasive suspiciousness, but she never expressed any psychosis. She continues to work, so this is a good case of paranoid personality disorder. Schizoid prefers solitude, no paranoia. Schizophrenia would have psychosis, and delusional disorder is a fixed false beliefs, not just persuasive suspiciousness. So, lifelong mistrust, no psychosis, paranoid personality disorder. Mistrust, no psychosis, paranoid personality disorder. What is the best diagnosis? Bulimia, binge eating, anorexia nervosa, binge purge type, night eating syndrome. A 25-year-old woman presents with a current episode of binge eating large amounts of food in secret, followed by distress, but no compensatory behavior such as vomiting or laxative. Her BMI is 33. She feels, so a BMI of 33, you can right there, like, eliminate anorexia. She feels guilt and loss of control during these episodes. Physical exam shows no animal erosions or parotid swelling. What is the best diagnosis? So this is binge eating disorder. Recurrent binge without purging. Bulimia requires compensatory behavior. So that she would be vomiting, she would have like a Russell sign on her knuckles. Anorexia, BMI would be low, and night eating, eating after awakening, not binges. Binges plus obesity, no purging, binge eating disorder. What is the most likely diagnosis? So, alcohol withdrawals, delirium, Wernicke, alcohol hallucinations. A 33-year-old man is admitted for severe agitation, diaphoresis, and confusion after stopping alcohol abruptly. He is tremulous, hypertensive, and tachycardic. Family reports heavy drinking for years. On hospital day 2, he develops a vivid visual hallucinations of insects crawling on the wall. What is the most likely diagnosis? Well, this is delirium tremens. So again, time frames are everything in psychiatry. So 48 to 96 hours post withdrawal, hallucinations, and autonomic instability. So withdrawal seizure occurs within 24 hours. Wernicke confusion, ataxia, ophthalmoplegias, alcohol hallucinations occur early, stable, vitals. So give away 2 to 3 days after withdrawal, plus hallucinations, plus autonomic instability, delirium tremens. So if you knew nothing else, and you can just see the patients here in the hospital day 2 with all the presentation, you could have said delirium tremens would be correct answer. Which personality disorder is most consistent? Histrionic, borderline, narcissistic, dependent. All right, let's see what this patient has. A 40-year-old woman presents with excessive emotional attention-seeking behavior. Well, right there, you can select histrionic and move on. She dresses provocatively for medical visits, is overly dramatic in describing symptoms, and becomes inappropriately flirtatious during the interview. Her relationships are often shallow. So, histrionic, attention seeking, provocative, dramatic. Borderline would be unstable relationships, self harm, narcissistic grandiosity, entitlement, dependent, submissive, clingy. So, overly dramatic, seductive, histrionic personality disorder. A 29-year-old man presents with recurrent episodes of palpitations, chest tightness, and dizziness occurring exclusively when he must give presentations at work. He fears embarrassment and avoids career opportunities requiring public speaking. He denies unexpected attacks at other times. Which diagnosis is most likely? Panic disorder, social anxiety disorder, general anxiety disorder, and agoraphobia. So we know this patient is afraid of public speaking, so that will fall under social anxiety disorder. So fear of social scrutiny in performance situations. Panic attack will occur unexpectedly. It's not situational. General anxiety disorder, chronics, no situational panic, and this one didn't even give us a time frame. So, and agoraphobia is a fear of escape being difficult, not scrutiny. So fear of embarrassment during performance, social anxiety, give this patient propranolol and they'll do just fine. Which is the best next step? Start propranolol, give dantrolene, administer diphenhydramine, add benztropine. A 36-year-old man presents with rigidity, confusion, and fever 1 week after starting fluphanazine. Exam shows lead pipe rigidity and autonomic instability. Labs reveal elevated creatine kinase, which is the next best step. So again, there was a very similar question earlier. So we're going to give dantrolene treatment for neuroleptic malignant syndrome, propranolol is for akathisias, diphenhydramine for dystonia, and benzodiazepine for dystonia and Parkinsonism. So when patients present with fever, rigidity, increase in CK, after antipsychotic, you should be thinking neuroleptic malignant syndrome and give that patient dantrolene or bromkriptine. A 20-year-old, a 28-year-old woman presents with a 6-month history of low mood, punctuated by brief 3 to 4 day periods of increased energy and reduced need for sleep. During up periods, she talks fast and starts projects, but she keeps working and has no legal or financial consequences. She denies psychosis. 2 years ago, she had a 3 week episode of depressed mood with anhedonia and hypersomnia. Thyroid function is normal, and she does not use substances. What is the most likely diagnosis? Bipolar I, cyclothymic, MDD, bipolar II. Well, if you look at a time frame, you'll figure out this is a bipolar II disorder because she presented with at least one hypomanic episode, no marked impairment, and one major depressive episode. So she had a brief 3 to 4 days of periods of increased energy and reduced need for sleep. If that was greater than 5 days, that would qualify as mania and should be more like bipolar one. But since it only lasted 3 to 4 days, and she also had that episode of depressed mode, so that puts her in a bipolar two disorder. Bipolar 1 only requires mania with marked impairments and psychosis. Cyclothymic should be dealing with this for greater than 2 years of symptoms without full MDE or hypomania, and major depressive disorders, just a history of hypomania rules it out. So giveaway up period with impairment and prior major depressive episode equals bipolar 2. All right, so which is the most effective treatment approach? Exposure-based cognitive behavioral therapy, long-term benzodiazepines, beta blockers, psychodynamic psychotherapy alone. A 44-year-old woman reports intense fear of flying that began after a turbulent flight 2 years ago. She has experienced palpitations, the shortness of breath when boarding, and has canceled multiple work trips despite career consequences. She is otherwise functioning well and has no unexpected panic attacks in other settings. She requires the best long-term fix rather than one-time medication. Which is the most effective treatment option? Well, for her would be exposure-based CBT. So first line for specific phobias, durable effect. Benzodiazepines are always for short-term relief. Beta blockers is performance anxiety. This is not phobia related. And a psychodynamic therapy is not the first line for phobias. So specific phobias, graded exposure. Which, I'll just start from the top. A 63-year-old man on a high-dose alprazolam for years runs out of medication and presents with tremors, insomnia, anxiety, and brief visual illusions. Vitals show tachycardia and a mild hypertension. He is diaphoretic but afebrile. There is no alcohol use or labs are unremarkable, which immediate management is indicated to prevent progression to seizure and delirium. Well, that would be a long-acting benzodiazepine like diazepam with taper, standard for benzodiazepine withdrawal. Propranolol may reduce the tremor but does not prevent seizures. Haloperidol can lower seizure threshold and worsen the withdrawal, and carbamazepine, sometimes adjunctive but it's never a first line for this seizure withdrawal. So benzo withdrawal, substitute long-acting benzo, gradual taper. So this patient presented with seizures and progression to delirium. So switch to long-acting benzodiazepine and taper him off. What is the most likely diagnosis? OCD, body dysmorphic, illness anxiety, anorexia. A 26-year-old graduate student insists that a benign mole is monstrous and spends hours daily taking selfies from an angle to prove the defect. Dermatology biopsy was normal, yet she avoids social events and poorly seeks cosmetic consultations. She recognizes the concern is excessive but feels compelled to check mirrors. BMI is normal, and she denies purging. What is the most likely diagnosis? With normal BMI, you can rule out anorexia. She denies purging, so obsessive compulsive disorder, body dysmorphic disorder, and illness anxiety disorder. So this is not an illness anxiety. She's checking mirrors. So it has to be body dysmorphic disorder. So sometimes if you're not sure what the answer is, so knowing the like ABCD answers, what they present with, you can kind of rule in and rule out things like we just did in this case. So body dysmorphic disorder is preoccupation with imaged defect, repetitive behavior, and impairment. OCD is broader obsession compulsion, not focused on appearance. Illness anxiety is a fear of disease, not appearance. And anorexia is weight shape with a low BMI. So appearance preoccupation, mirror checking despite normal exam, BDD. What is the most likely diagnosis? Oppositional defiant disorder, intermittent explosive disorder, antisocial personality disorder, and conduct disorder. A 17-year-old boy has escalating fights, truancy, theft from relatives, and cruelty to a neighborhood cat. He lies frequently and shows little remorse. School suspension followed an incident where he threatened a teacher with a chair. Cannabis use is occasional, and there is no psychosis. What is the most likely diagnosis? Well, this is a conduct disorder because he's under 18. So, conduct disorder is a violation of the rights of others and social norms, including aggression and cruelty to animals. And ODD is oppositional defiant disorder. These kids will be argumentative, they'll be defiant, but without any serious violation or aggression. So, oppositional defiant disorder, he will not be threatening the teacher, he will not be using cannabis. Intermittent explosive, It's a discrete outburst without persuasive violent patterns. Again, no violence. An antisocial must be greater than 18 years old with a history of conduct disorder. So giveaway, he's under 18, he's aggressive, he steals, he's cruel. That is a definition of the conduct disorder. So again, time frame gave us an answer in this one. Which monitoring test is most essential at regular intervals to minimize complications? Serum creatinine and thyroid function test, prolactin level, LFTs, and creatinine kinase. A 30-year-old woman with a bipolar I disorder had a severe manic episode last year requiring hospitalization. She is stabilized on lithium and reports good adherence. Baseline labs are normal. Today she notes increased thirst and a fine hand tremor. Pregnancy test is negative. Which monitoring test is most essential at irregular intervals to minimize complications? So this is a patient with bipolar 1 on lithium. So you always want to be checking their serum creatinine and thyroid function tests for all people on lithium. So renal creatinine and thyroid TSH monitoring on lithium can cause nephrogenic DI and hypothyroidism. Prolactin level, that is for antipsychotics, not lithium, raises prolactin. LFT is more relevant for valproate or carbamazepines, and CK relevant to NMS and rhabdo. No lithium routine monitoring here. So giveaway, lithium, kidneys plus thyroid. So for all patients taking lithium, we want to be checking their kidneys and their thyroid frequently. What is the most likely diagnosis? Paranoid personality disorder, schizophrenia, delusional disorder, jealous type, and schizoaffective disorder. A 38-year-old man believes his wife is unfaithful despite lack of evidence. He hired a private investigator and installed cameras, yet remains convinced. He functions well at work and denies hallucination or disorganization. This conviction has persisted for 10 months and is not bizarre. Which is the most likely diagnosis? Well, this is clear cut a delusional disorder. Single, non bizarre delusion team lasting greater than 1 month, relatively preserved functioning. So he's just focusing on believing that his wife is unfaithful. This has been going on for a few months. He's doing well at work. He has no hallucinations or disorganizations. So, which would be in paranoid personality disorder, which is pervasive distrust without fixed delusions. Schizophrenia is broader psychotic symptoms. Schizoaffective requires major mood episode with psychosis. So giveaway, one fixed plausible delusion plus intact function equals delusional disorder. One fixed plausible delusion and intact function. Which is the most appropriate first-line intervention? Atomoxetine, applied behavior analysis with speech therapy, risperidone, parent-child interaction therapy for ODD. A 5-year-old boy has persistent deficits in social reciprocity, limited eye contact, and restricted interest in train schedules. He speaks in full sentences, but struggles with back and forth conversation and insists on strict routines. Hearing test is normal. There is no regression of language skills after age 2, which is the most appropriate first line intervention. Well, that would be applied behavior analysis with speech therapy, cornerstone for autism spectrum disorder. So, patient presents with clear signs of autism spectrum disorder, and the first line treatment should be applied behavior analysis and speech therapy. Atomoxetate is for ADHD, not primary for ASD core deficits. Risperidone. Well, this is something we'll give for severe irritability or self-injury, not first line for core symptoms. And parent-child interactive therapy is for disruptive behavior, not for this case. So giveaway ASD, early intensive behavioral therapy. Which acute complication is most concerning and requires immediate monitoring? Hyperprolactinemia, hyponatremia, hypertensive emergency myocardial ischemia, acute angle closure glaucoma. Well, which acute complication is most concerning? Well, we should just pick this one. A 24-year-old man presents with euphoria, hypervigilance, tachycardia, papillary dilation, and a severe psychomotor agitation after an all-night study session. He has chest pain and picks at his skin. Urine tox is pending. Which acute complication is most concerning? Well, yeah, if anything says MI, just most concerning, select that and move on. Hyperprolactinemia is antipsychotics, not stimulants. Hyponatremia, more with MDMA and polydipsia. And angle closure, anticholinergics can precipitate, not stimulate commonly. So giveaway, this patient's probably taking stimulants, stay up all night, so he's feeling tachy, dilated pupils, chest pain. You should be thinking MI. Alright, guys, we're two-thirds done. What is the most likely diagnosis? Acute stress disorder, post PTSD, adjustment disorder, general anxiety disorder. A 32-year-old woman presents with intrusive memories of sexual assault 3 weeks ago. She avoids the area where it happened and has nightmares and hyperarousal. She has difficulty concentrating on work and feels detached from friends. She denies substance use and is not suicidal. What's the most likely diagnosis? Well, you can see that she's been dealing with these symptoms only for 3 weeks, so that should be acute stress disorder. So, yeah, 3 days to 1 month after the event. PTSD requires a duration lasting greater than 1 month. Adjustments would be subthreshold and not trauma specific. And general anxiety disorder is not trauma specific as well. So, trauma that last trauma that happened less than 1 month ago, acute stress disorder. Which medication offers the best chance of improvement? Risperidone, haloperidol, clozapine, and ziprasidone. I never heard of that medication. All right, so rule that one out. So, 52-year-old man with a schizophrenia has persistent negative symptoms. Ovulation, flare effect, and minimal response to two adequate antipsychotic trials. He has no history of agranulocytosis, and the baseline CBC is normal. He lives with family and has a frequent self-neglect but no suicidal ideations. Which medication offers the best chance of improvement? Clozapine, effective in treating resistant schizophrenia and reduces suicidality. Risperidone already failed 2 trials. Clozapine is next. Haloperidol, unlikely to help after multiple failures, and similar class, not superior to clozapine. So, when you think about treatment-resistant schizophrenia, so this 52-year-old man with schizophrenia has persistent negative symptoms, no response to 2 other trials, no history of granulocytosis. He lives with a family and has frequent self-neglect, but no suicidal thoughts. So give that man clozapine and he'll improve. Which is the best initial treatment? Stimulant medication, parent management training with behavioral interventions, mood stabilizers, and antipsychotic medication. A 9-year-old boy is defiant at home and school, arguing with teachers, deliberately annoying peers, and blaming others for his mistake for over 8 months. He has no theft, cruelty, or serious rule violation. Academics are average, and he shows remorse after cooling down. What's the best initial treatment? Well, this would be somebody with oppositional defiant disorder. He's under 18, no violence, but he's defiant. And for that, parents management training behavioral therapy is the first line. So stimulants are for ADHD, not ODD. Mood stabilizer, not the first line, and antipsychotic are reserved for severe aggression. So ODD, psychosocial parent training first. What intoxication best explains these findings? Hallucinogen, LSD, opioid, sedative, hypnotic, and cannabis. A 24-year-old man presents with anxiety, paranoia, conjunctival injections, tachycardia, and increased appetite after smoking a new strain. He reports intensified sensory perception, a slowed reaction time. The next day, he has impaired short-term memory. What intoxication best explains these findings? Cannabis. So, yeah, this boy was smoking, and you can tell the answer was in conjunctival injection, increased appetite, tachycardia, memory impairment. So classical stoner signs. So LSD will have vivid visual hallucinations, mydriasis, and no conjunctival injection. Opioids will be meiosis and respiratory depression, and sedatives will have ataxia and nystagmus with benzos, and no munchies or red eyes. So, giveaway, he has red eyes, he has munchies, he has short-term memory problems. Think cannabis. What is the most likely diagnosis? OCPD, OCD, avoidant personality, and schizoid personality disorder. A 36-year-old office manager reports years of perfectionism, excessive devotion to work, and difficulty delegating tasks because others won't do it right. She keeps lists for everything and is rigid about minor rules. Her apartment is orderly but not cluttered, and she sees no need to change. She denies obsessions and compulsions and functions well but has strained relationships. What is the most likely diagnosis? Well, OCPD fits this criteria the best. Egocentric perfectionism and control, no intrusive obsessions or compulsions. So, in a question stem, she says, others won't do it right, but she also denies obsessions or compulsions, leading us to OCPD away from OCD. Avoidant would be social inhibition, fear of rejection, and a schizoid is detached, limited effect, no perfectionism. My way is right, plus perfectionism, OCPD. Which medication best fits his requests? Bupropion, varenicline, clonidine, and nortriptyline. A 58-year-old man with a long-standing tobacco use wants help quitting. He tried nicotine patching but relapsed. He has no seizure history, drinks socially, and has mild hypertension. He is motivated and asks for medication that reduces cravings but partially stimulating nicotine receptors. Which medication best fits his request? Well, that would be varenicline, partial agonist, nicotinic receptors, reduces cravings and rewards. Bupropion, helpful but not NDRI, no partial nicotine agonist. Clonidine off-label aid, not a first line. No triptyline, second line TCA, more side effects. So giveaway, partial nicotinic agonist. Think about varenicline. Man, some of these names are crazy. All right. A 42-year-old woman presents with fatigue, poor concentration, and insomnia for the past 2 months. She reports feeling of worthlessness and guilt, stating she has failed her family. She denies hallucinations or major manic symptoms. Physical exam is unremarkable and the thyroid levels are normal. Which is the best initial treatment? Fluoxetine, risperidone, lithium, or lorazepam? Well, insomnia, poor concentration, fatigue for past 2 months, feeling of worthlessness and guilt, points out to major depressive disorder, and fluoxetine as the first line treatment. Risperidone is antipsychotic, not the first line unless psychotic features present, which it does not have. Lithium is a mood stabilizer for bipolar depression, and lorazepam is benzodiazepine, not the first line due to dependency risk. So MDD, SRI, first line. A 24-year-old college student reports persistent worry. So persistent worry right there, I'm thinking general anxiety disorder. About academic failure despite strong grades. She has difficulty sleeping and often experiences muscle tension and restlessness. These symptoms have lasted for 9 months and interfere with her daily functions. Substance use and thyroid screening are negative. What is the most likely diagnosis? Again, so persistent worry greater than 6 months, general anxiety disorder. Panic disorder will be episodic attacks, not chronic daily worry. Adjustment disorder would be within 3 months of stressor, shorter course. And the cyclothymic would be mood swings, not anxiety driven worry. So greater than 6 months of worry, GAD. A 27-year-old man is brought in after being found walking naked in the street, claiming he is the chosen one to save the world. He has pressured speech, decreased need for sleep, and grandiosity. Friends report this episode has lasted 1 week and he has missed work. No substances are detected in urine. What is the diagnosis? Well, we have symptoms that lasted more than 1 week. So mania lasting greater than 1 week. I'm thinking bipolar 1 because of the severe impairment and the time frame. So schizophrenia would be psychosis lasting greater than 6 months without mania or depression. So if you see mania, like I mean, he's walking naked in the street, he's chosen one to save the world. So the guy's obviously manic. And then schizoaffective would be psychosis with mood symptoms, but psychosis persists alone. And bipolar 2 would be hypomania. This is a week, so that one is out. So 1 week of mania with impairment, bipolar 1. Which is the most appropriate first line treatment? A 6-year-old boy has difficulty following instructions, often interrupts in class and fidgets constantly. His teacher reports disruptive behavior daily, lasting over 6 months. Parents describe similar behavior at home. His grades are declining despite average intelligence. Which is the most appropriate first line treatment? Tamoxifen, cognitive behavioral therapy, methylphenidate, or clonidine. And for this patient, methylphenidate stimulant is the first line for ADHD. So for ADHD, we have symptoms that are over 6 months and in two settings. That's a big one. For ADHD diagnosis, they have to be having issues at home and in school. So two different settings. Tamoxifen is a non-stimulant. It's a second line. CBT helpful but not first line. And clonidine is alternative for refractory cases. So ADHD kids stimulant first. Which medication is most appropriate? A 58-year-old man is brought by his wife for memory loss and personality changes. He often misplaces items and becomes lost in familiar places. Neuroexam shows mild disorientation at time. MRI reveals cortical atrophy. Which medication is most appropriate? Well, this is a patient with Alzheimer's because there's a diffuse cortical atrophy and all other symptoms. So we're going to give him donepezil. So it is an acetylcholinesterase inhibitor for mild to moderate Alzheimer's. Haloperidol is given for agitation, but not a cure treatment. Memantine for moderate to severe Alzheimer's. And fluoxetine is antidepressant, not dementia therapy. So giveaway, early Alzheimer's, done, Pezil. So early Alzheimer's, given some to be done, Pezil. What is the most appropriate management? A 21-year-old woman presents with a refusal to maintain body weight, intense fear of gaining weight, and distorted body image. BMI is 16. Vitals show bradycardia and hypotension. Labs reveal hypokalemia. What is the most appropriate management? Outpatient CBT, nutritional rehabilitation with monitoring, fluoxetine only, and antipsychotic therapy. Well, this lady has a very low BMI. She has some electrolyte imbalances, bradycardia, and hypertension. So, nutritional rehabilitation with monitoring should be the first line for anorexia. CBT is important, but is not a first line acute medical compromise. Fluoxetine is not effective, and antipsychotics sometimes adjunct, but not a primary. So, anorexia, refeed plus monitor. What is the best treatment? 35-year-old combat vet reports nightmares, hypervigilance, and avoidance of crowds for 8 months. He startles easily and struggles with anger outbursts. Substance screening is negative. What is the best treatment? Sertraline, risperidone, diazepam, and lithium. So SSRI is a first-line treatment for PTSD. And given this vet is experiencing symptoms for greater than 1 month, that classifies as PTSD, and we should treat him with a SSRI. Risperidone is used for refractory cases only. Diazepam is not the first line due to the dependency, and lithium is a mood stabilizer. It's not used in PTSD. What is the most likely diagnosis? Paranoid, delusion, paranoid personality, schizoid. A 40-year-old man presents with a chronic suspicion that the co-workers are plotting against him. He has no hallucinations or mood episodes. His relationships are strained due to distrust, but he has maintained employment. No substance use is reported. What is the most likely diagnosis? Well, this is a good case of paranoid personality disorder. Lifelong distrust without psychosis. So, paranoid schizophrenia would have hallucination or disorganized thoughts. Delusional disorder is a fixed false belief, no broad distrust. And schizoid, social detachment, no paranoia. So, lifelong distrust, think about paranoid personality disorder. What is the most likely diagnosis? A 33-year-old man describes hearing voices for 3 months, telling him he is worthless. He also reports insomnia and depressed mood for 4 months. During this time, hallucinations occur only when his mood symptoms are active. What is the most likely diagnosis? Schizophrenia, schizoaffective major depressive disorder with psychotic features, and bipolar disorder. So this is actually a major depressive disorder with psychotic feature. Psychosis only during depression. Schizophrenia will be psychosis independent of mood. Schizoaffective psychosis must be present for 2 weeks without mood symptoms, and bipolar mania absent here. So psychosis tied only to depression, MDD with psychotic features. What is the diagnosis? A 17-year-old boy has sudden episode of palpitations, sweating, trembling lasting about 20 minutes. He fears he is dying during the attacks. Medical workup is negative. He avoids leaving home for fear of having attacks in public. What is the diagnosis? Panic disorder with agoraphobia, GAD, social anxiety, illness anxiety. Well, we know it's not illness. So panic disorder with agoraphobia, recurrent panic plus avoidance. General anxiety disorder, chronic worry, no panic episodes. Social anxiety, fear of embarrassment, no random panic. And illness anxiety, preoccupation with disease. So when you think about panic attacks, avoiding certain situations, panic disorder with agoraphobia. Which is the best therapy? CBT, dialectical, psychodynamic, group therapy. A 25-year-old woman has a history of unstable relationships, fear of abandonment, impulsivity, and recurrent suicidal threats. She describes chronic emptiness and anger outbursts. Which is the best therapy? Well, so this is patient with bipolar disorder, unstable relationships, fear of abandonment, impulsivity, recurrent suicidal threats. All points to borderline personality disorder, and given that she's having all this chronic emptiness, anger outbursts, dialectical behavioral therapy is a gold standard for borderline personality disorder, DBT. So CBT is effective in many conditions, but not the first line here. Psychodynamic, no evidence-based first line, and group therapy may actually worsen instability. So borderline personality disorder, you should be thinking dialectic behavioral therapy. A 45-year-old man presents with a difficulty controlling alcohol use, neglect of responsibility, and recurrent use despite consequences. He experiences tremors in the morning and drinks to relieve them. Labs show elevated GGT. What is the best first step in management? Naltrexone, disulfiram, acamprostay, and a detoxification with benzodiazepine. Well, this is a good case of an alcoholic. Drinks in the morning. Lab showed elevated GGT, so we want to treat it with detoxification with benzodiazepine, first for acute withdrawal risk. Naltrexone for relapse prevention. Disulfiram, a versatile agent, not a first line, and this is for maintenance therapy post detox. So alcohol withdrawal, benzos first. A 29-year-old man presents with excessive preoccupation with having ALS despite normal neurological exam. He spends hours researching online, frequently visits multiple doctors. He has persisted for over a year and causes significant stress. What is the diagnosis? Illness, anxiety, somatic symptom disorder, OCD, and factitious disorder. Well, this is a clear case of illness anxiety disorder. He is all preoccupied with ALS, but no major somatic symptoms. Actual symptoms would be present in somatic symptom disorder, OCD, intrusive thoughts, but no health preoccupation. And factitious is intentional falsification present here. So fear of illness without symptoms, illness anxiety. A 72-year-old woman presents with auditory hallucinations for 10 years. She has flat affect, disorganized speech, and social withdrawal. Symptoms are persistent without mood episodes. CT scan is normal, which is most likely diagnosis. Schizoaffective disorder is not, because she's been having these symptoms for more than 6 months. Schizophrenia, delusional disorder, major depressive disorder with psychotic features. So this is a clear cut of schizophrenia. She's having hallucinations with auditory hallucinations to that for greater than 6 months. With social dysfunction, schizoaffective psychosis, mood symptoms, delusional, isolated delusions, no broad psychotic features, and MDD is definitely out here. Okay, so which is the most likely diagnosis? Cover this. All right. Last question, guys. This is awesome. You're there. So, what is the most likely diagnosis? Malingering, somatic, conversion, factitious. A 30-year-old nurse presents with headaches and abdominal pain for which no medical cause is found. She has been hospitalized multiple times with elaborate stories about her symptoms. Chart reviews reveals incontinence and eagerness to procedures, which is the most likely diagnosis. Well, this is a good case of factitious disorder, intentionally falsification to assume a sick role. Malingering, there's no external gain. She's not talking about money or lawsuits or anything like that. Somatic symptoms, genuine symptoms with distress, and conversion is the neurological symptoms in compulsive findings. So one sick role, factitious disorder. Thank you guys for watching. Thank you. I hope you find this video helpful. Give it a thumbs up, leave a comment. Let me know where you are in your schooling. Check out a book. You'll find another 120 questions like this. And I'll see you guys in the next video.